Hello, everybody. I'm Ira Kirschenbaum. I am the editor of the Journal for Orthopedic Experience and Innovation, otherwise known as the Journal for the Rest of Us. I am pleased to have a probably most timely topic tonight, maybe the most important one of the year. It's no surprise we're having it before Thanksgiving that we are doing this. We have three amazing panelists to discuss fluoroscopy, health issues, surgeon burnout, and a variety of topics all related to that. We have three people who have written on this, who have coached people on this, who mentor people on this topic, and it's across the board. I think one of the hidden and less talked about major problems that is coming down like a steamroller into orthopedics. So I'd like to first introduce our panelists. I'll ask them to introduce themselves. I'll start with Antonia Chen. Please introduce yourself, Antonia.
Hi, my name is Antonia Chen. I'm a hip and knee arthroplasty surgeon located in Dallas, Texas.
And Lisa Cannada
Hi, I'm Lisa Cannada. I'm an orthopedic trauma surgeon and I work in Charlotte, North Carolina.
and Jeff Smith.
Hi, I'm Jeff Smith. I'm in San Diego, California. I'm an orthopedic trauma surgeon and also a big surgeon wellness advocate.
Excellent. Excellent. So we have a big agenda tonight to talk about a number of things. But the first thing I'd really like to talk about in general is why is this a big problem? Let's talk about why burnout. Let's talk about why burnout. And then we'll get into specific things like musculoskeletal pain, wear, radiation. We're going to cover the whole gamut tonight. All right. But
How long do we have?
we have
We need
three.
more than an hour. We need days for this.
I'm willing. I'm willing. I got a lot of hard drive space for recording, Antonia. It all works out. So, Antonia, why don't you start? Let's give us the why of the breadth of this issue and the why of this issue.
It's really an interesting thing, and I defer to my more experienced and phenomenal colleagues on this call. I think in the past, what happens is when we were in residency and fellowship and early attending, it was just put your head down, work, and don't think about anything else. Work as hard, as fast as you can, and burnout wasn't even a word in our vocabulary, I'd say, even 10 years ago. It's really something that's really come to light, I'd say, in the last 5 to 7 years, I would say. And I think a few things really brought this to light. One, as someone noted in the chat very astutely, is that orthopedic surgeons have the highest suicide rate out of surgical subspecialties. That is a daunting and scary characteristic. And that is something that we face with due to the pressures of performing, due to the pressures of financial pressures, due to the pressures of family life, due to the pressures of any other way that we want to balance our work-life balances, whatever you want to call that. Not that we can actually balance it, but it's a topic that's truly topical now because it's something that we all struggle with. And I love the fact that we're talking about this because we've never really given this words. Everyone feels it. Everyone's talked about it, and people, coming out of committees or coming in and out of all sorts of stuff because there's only so many hours in a day. But to actually put our fingers on it, talk about it, bring it to light. And with burnout comes things like surgeon wellness. A lot, again, we talk about the patient and the patient outcomes. And we want patients to have good outcomes. But you have to talk about the person who's doing the surgery as well, too. So this is a very topical area. And I think it's an important area to prevent the suicide rates that we have seen and to empower surgeons to talk about it so that we can be better.
Excellent. I also want to make a comment. If you have comments, please put them in the chat section, and I'll frequently call on you, ask you to take your video off because this is an open mic session. I'm going to bounce to Jeff and say, Jeff, tell me your why is this such a big deal and how prevalent it is, and what have you seen in your world of wellness coaching and a variety of things?
Well, I think Antonia did a great introduction there. I mean, I think it's very much something that wasn't talked about. Now that we are talking about it, I think we're realizing it's a pretty complex subject. I mean, I think we joked around a little bit about the timing, but just like any other orthopedic topic we talk about, we can go on and share many facets of this. I'm just excited that we're talking about it enough. I think sometimes we spend, I guess, in my humble opinion, we sometimes argue over the terminology. Some people don't like the word burnout. Some people want to call it moral injuries. Some people want to call it focus on the wellness. To me, I think that shows all the different facets. And I think they're all relevant. We do know that resilience is a component of this, but it's not a lack of resilience. All of us become very, very resilient. For me, I think one of the problems is that we focus on negative resilience and the training you learn from all the painful lessons rather than the positive resilience that you can get through encouragement and support and compassion from our colleagues, our mentors, teachers, etc. So I think there's a lot there. I know that from my own experience, I had to kind of figure it out for myself and figure out ways to manage it, avoid it, whatever you want to say, or even just sort of work through it. I actually think burnout is a positive thing. It's basically our personal warning system that things that we're doing are not aligned with what we really want to be doing. And you can have a lot of misalignment for people that are in the service injury where we're caring and giving, but you can only have so much before it is a tipping point, and then you just don't want to do it anymore. I'll pause there because I think we have great other comments. I just think it's our occupational hazard.
Lisa, let's hear some
Yes,
thoughts.
I love the comments that have already been said, but I'm going to bring up the residents and I'm going to start with them because their rate, we tend to think that what happens during residency is not going to, it's not really burnout. They're just tired because they're residents and, we always blow it off. When we look at the literature out there, there are articles that are published that show that there's a rate of burnout in residents of over 50%. There's a rate of alcohol use that is hazardous in residents. It's over 50%, and 10% have used illicit drugs. So we have to acknowledge that residents also have this problem and that we need to think about what we can do. And there's a couple things, in that realm. So I'm going to say that we got to look at the culture that they're training in and how we interact. We know we have millennia, there's so many different levels of training and communication. We need to understand where they're coming from and effective communication to them, effective teaching and effective learning, and also effective resources. A big problem for residents also is learning how to deal with conflict. Conflict happens in the real world. It happens in residency, and we need to arm them with tools, not only, to be good physicians, but also to deal with conflict so that they don't have inner turmoil. So I believe that we need to acknowledge the problem exists in residency, and we have to develop and acknowledge it and help them and look at our contribution to how we can improve that for them.
Yeah, I want to pop up a screen for a second. It's sponsored tonight is Stryker, but I actually found this on the Stryker site because someone from Stryker directed me there. That's how you usually find things. And I know that Antonia, you've been a leader in this, but I've looked at these studies. Studies have shown that orthopedic surgery is mentally and physically demanding. 50% burnout. That's what you talked about. 77% of back pain. 100% of the moderators have back pain. 74% have neck pain. 86% at least one musculoskeletal condition since training linked to practicing orthopedics. And that's not even talking about the psychology and everything else. So, it's a amazing thing that all this happens. I'd like to spend a little time asking panelists, where do you think are some of the key causes or the key triggers of burnout. Meaning something like, is it an abusive work environment? Is it administrators now calling the shots? Is it pre-authorization and getting paid less than you think you're worth? I mean, what are some of the underlying triggers and causes? Lisa, what do you think? What do you think?
Well, you hit some on the head right away. So I think the underlying triggers and causes depend on your age and your the generation you came from. For example, I'll never forget when we started the electronic medical record, which is we're all used to now, but not everyone is. And I was in the training and I had an older surgeon that just walked out. He said, I can't do it. Didn't think he could learn something new. So that's one thing. So it can be the paperwork. It used to be paperwork. Now it's electronic paperwork. And it's also the comfortable, the ease that someone feels they can use it. So that's one issue. So I wanted to bring that up because we need to be cognizant of people that are older and generational issues. A big cause you mentioned in a big important trigger is the culture. The culture is set by the leadership. And if the culture is not positive from the top, then I mean, it shows not just in orthopedics, it shows in teams. Just look at some of the disasters in college football, for example, right now, because they are not cohesive. They don't have a culture, and we need to create positive culture. And then one last thing is there are if you're, I want to give time for everybody else, but private practice versus academics, there's different demands. Academics, the need to, meet the goals for promotion, for example, causes a great amount of stress. So one way that we can help minimize stress and burnout is really start educating them from the time they start and give them a step. It's much easier to do little steps, baby steps every year than to all of a sudden be given a promotion packet and not know what to do or how to achieve those goals. So I just wanted to touch on 3 aspects to cover our wide audience.
Yeah. Antonia, what do you think? So you've been in a number of leadership positions in the last few years. You've seen cultures, you've inherited cultures. What do you think is some of the I call them triggers, but we can call them causes or environments.
So Lisa hit the nail on the head. The biggest one that surveys have shown is electronic medical records. But I lump that in the big picture of loss of autonomy. I think it's the biggest thing as being a surgeon. It used to be, I used to run things the way I like to run it, and I have a system for it. And if it's all by paper, then I do it all by paper. Then your health system comes in and goes like, your paper's gone. Now you've got to do it like this. Learning new things is a very hard thing for anyone at any stage. And it's obviously easier when we're younger, harder as we get older. So loss of autonomy is, for example, our staff has come in here and says like, you have to have 4-hour clinical slots for all of your clinics. So if you want to take vacation, you have to go through this pathway. Or if you want to do something else, it's a different pathway. And so loss of autonomy, I think, is one thing. And then surgeon safety is another thing. The surgeon safety that really has hit home are 2 areas. One of them is we've known orthopedic surgeons who've been murdered by their patients. And that's scary and daunting, right? We're here to try to help take care of our patients. And yet we have lost colleagues to violence that is beyond scary. And the second thing with regards to surgeon wellness is something that's near and dear to my heart. And Lisa knows this well too, is cancer prevention. We know that for the women in orthopedics have 4 times the risk of breast cancer than the general US population. And I know of people who are orthopedic surgeons, females, who have died from this condition. I've known multiple people who've been diagnosed with this condition. Now, it is a condition that's pretty prevalent. I think it's 1 in 8 women are diagnosed with breast cancer, but to have such a high rate in our population is scary. So, for example, you showed that website, right? I don't use fluoro when I do my total hips. I did at a period of time. I discovered robotics and I stopped using fluoro, and I use a robot specifically because I don't want to do fluoroscopic imaging. I don't want to have cancer risk for myself. I don't want to have cancer risk to my patient. I don't want to have cancer risk to anyone in the OR with me. We have people of all different ages in the OR, and a lot of times young, nurses, techs, anything like that. And to have them breast tissue exposed to that is not a good thing. I think back to my residency, and now one of the initiatives that we're doing for all of our residents, we're giving them all lead. It's one of those things where you got to put your money where your mouth is. And if we really do want to prevent things like that, it empowers them to one more thing that we can have control over, as opposed to someone else telling us what to do.
Jeff, your thoughts? Oh, you're on mute.
I love all the comments that you had kind of mentioned, which of these things, and I'd say all the above. And I think Lisa and Antonia highlighted that as well, because there's just so many factors. I mean, just the stats that you were showing, if much of the time you're operating, you're in pain. Now that may progress in your career, but if you're in pain while you're doing the thing that you enjoy most, that's kind of a challenge there, right? And that you're having to kind of manage that, hide that, suppress it, whatever we all do to kind of get through and still do the thing that we probably enjoy the most. That's a big deal. I mean, I think the other point to make is that it's kind of often it's what we anticipate or hope, what we think our expectations are in our job and our career, and then falling short of that. So if there's a big split between expectations and reality, then to me, that's a high driver to either burnout or just a lack of fulfillment and well-being in your career. So, some of these things are not polar opposites. They have other nuances to them. But I think, we're trying to avoid the one in general, and we're aiming towards well-being and wellness in our career, satisfaction, all these positive things. So I think and that's where the leadership key comes in. If you have leaders that help manage the expectations of a career, help guide you in your career, then that can certainly contribute to meeting expectations or coming very, very close. And so I think we have a lot of knowledge about the things that can drive us in the right direction. And that's, to me, where a lot of our focus ought to go. And that's including eliminating the things that drive us crazy. Okay, so you can't eliminate them. Anything that's a negative, you need to decrease the volume or dose. And anything that's a positive, you need to increase the volume and dose.
Well, I'd like to just tell two anecdotes and flip to the radiation part, because I have two trauma surgeons and I have a joint surgeon. And when you do joints, you do revisions, you're looking at fluoro all the time. Trauma, I can only imagine how much radiation is flying through the air. First one was a story from when I was a chief resident in 1989. I was a chief resident when I was 12. So when I was a chief resident in 1989, AIDS, especially in New York at the time, and the Bronx was rampant, and we were operating in a very large AIDS population, and I decided that I wanted to start using the Stryker suits, and they were relatively new at the time, the flight suits, and I wore the flight suits, and then one day they weren't available in the OR one day because they didn't really keep the par levels, because not a lot of people were using them, just me and Craig McAllister, who was my co-chief resident, and I said, I'm not going in on this case. It was a revision case. I was a chief resident saying this, and the chairman supported me. It was Ada Haberman. He was really an amazing guy. But the head nurse of the OR, the head perioperative nurse, literally said to me, "You're not going into the case because you're afraid of this disease, then you shouldn't have been a surgeon." And I said, you should be protecting your surgeons. But that was the mentality of not protecting surgeons. The next anecdote was when I was in private practice. I was in a solo private practice. Talk about autonomy. Wow, autonomy, solo private practice. The only person you get into an argument with is yourself, So I went to the hospital and I saw how old the lead shields were. So we actually checked them out and they were horrible. We brought in an expert to look at the holes. It was as if they didn't exist and people were using them. And administration just there was no alarm. There was no alarm. So let's flip to radiation for a little while because I think it's a cause of so many things. And what are you doing? Let's talk with trauma. Antonio touched a little bit, and we're going to go back to I think the direct anterior sort of reconstructive technology, the DART system, and some other things. But what are you doing in trauma now, Lisa, to mitigate this out of control radiation?
I wish that we each could make a difference in that. But the one thing I can say is education of the risks of radiation, so that we can begin to make everyone understand the career of an orthopedic surgeon is going to span 20 to 30 years or more, and radiation is cumulative, and we need to teach good habits young instead of everyone just freely, taking fluoro shots. I think that when we're recording cases, x-rays of the tibia, when tibias and femurs are logged in, I think that we should be recording the fluoro time for that. Because then we're going to begin to learn what we are doing and what we can do better. Until you understand what you're doing, and then you get out in the real world, and then if that fluoro machine after 5 minutes is going off and you're doing that regularly, you're going to glow in the dark at some point and you're going to have a cancer somewhere. And I think that education is important, that we need to, when we're training our residents, not just on technique, we need to teach them good judicious use of radiation. And we also need to talk, the trauma team today, for example, I had a young female with a hip dislocation, a female childbearing age. Her hip was reduced and we got the scan, and I'm like, I don't need any more studies. I don't need a stress exam under fluoro. I can see enough from the studies we have. So we need to think before we reflexively act. We need to teach our trainees that this is cumulative. We need to pay attention. It's just like everyone wears dosyometers, or you should. Do we actually look at them? And does anyone ever look at their fluoro time and dictate that? I think by starting habits where we teach everyone in trauma, for every case that you do, also record the fluoro time, is one of my big steps. And I think it's not just trauma that we need to be aware of. And I love Dr. Chen's, what she's doing. Get everyone lead. Everyone needs their own lead. It needs to fit. One size doesn't fit all. And we need to make sure it fits. We need to make sure it fits in the axilla, because men can get breast cancer too. And we did a survey of male surgeons, and there are male surgeons that had breast cancer. So get good fitting lead. We need to provide education. I could go on and on. So that's just some of my ideas, and I'll let
Antonia,
everyone else speak.
yourself and the fluoro the fluoro explosion, especially in revision hips, I find. But what are your thoughts?
So this is where technology is an amazing thing. There are technologies, robotics that are doing things like revision hips. And that's new. That's something that hasn't been in the horizon. And it can help with things like screw trajectory. It can help, which we a lot of times use for our cases. It can help for cup placement, again, what we use for our cases. So instead of having to take multiple fluoroscopic shots and images, then you take a single one. right? And then you get an image there. Or you do a flat plate and you have everyone step out and you do a single flat plate just to confirm everything looks good. And then you go ahead and finish the rest of the case. So exactly as Lisa's saying, really limiting the amount of exposure is key. Now the patient will get some exposure. There was a question in the chat asking about radiation dosage to the patients for a CT or an intraoperative O-arm. That is higher than obviously a single image. So if I'm taking a single image, both either fluoroscopy or through X-ray, those are the things I'm going to try to mitigate and reduce it. Do I need that intraoperative CT or not? That's a good question. The O-arm is a little bit different. That's a spine case. You'll need that. With regards to the support staff, there are actually some interesting studies, mostly in endovascular procedures that exist out there, but there is radiation exposure. But every 6 feet you go away, the less the exposure. So if the nurse is in the corner and further away from the source, and it also depends on where you are with regards to the radiation source. When you're taking x-rays yourself, try not to stand exactly where the source of the imaging is, and you get more radiation. If you're closer to it, you get less radiation if you step aside. There's also great studies where if you turn to the side, you can get exposure to the imaging in the chest region. So make sure your lead is good, well fitting. But if you face full on straight ahead, again with leaded glasses, then you can mitigate that because the rays are coming directly at you. So while you still have to take images because we want to have perfect pictures and we want to do a good job for our patients so we don't have to go back in again, there are ways that you can take these x-rays to make it safer for you as a surgeon and for you as your staff. Make sure the shields don't have cracks in them. One of the things that it happens is you take your lead at the end of a case, your sweaty mesh, you throw it on the table, and that gets micro cracks. And those micro cracks accumulate over time, and that lead becomes less effective over time. So get that checked by a radiation safety on a regular basis. It should be done yearly, and they're supposed to tag it and let you know that it's okay to use. So those are all the things short of mitigating the amount of x-ray you do or fluoro and flat planar x-rays you do.
It's really fascinating. We did a QA study at looking at unnecessary CAT scans from the emergency room at our hospital. So we had 2 independent orthopedic surgeons read through the charts of close to 300 cases that had CTs in the emergency room. And for the spines were 50% were unnecessary, and the non-spine were 88% unnecessary CAT scans. According to, we just had, there's a QA study, and we had 2 independent, a spine surgeon and a general orthopedic surgeon who looked at these. So we're irradiating all over the hospital as well. Especially the emergency room. I think the CAT scan is used more than the stethoscope in the emergency room. Personally, I think it's actually fascinating what you said about fluoroscopy time, because we are now in an era of efficiency, and everyone's getting reports from the hospital on how efficient they are in the OR or how many patients they've seen. Compared to the other surgeons, how much their prosthesis costs are. Has anyone ever seen a report from the hospital comparing fluoroscopy time between surgeons?
I never have, and that's why I'm talking about it, and I'll keep on talking till people listen. And I have done studies also where we did compare fluoroscopy time for residents and, junior versus senior residents, and also the first half of the year versus the second half of the year. And there are differences. And, we just need to teach good habits early. I'm always big in talking about residents, and we're doing a hip, for example, a hip nail. And how many times do they need an x-ray to show where the hip is? They should know where the hip is. The first fluoro shot should be when the guide pin is on bone, not to help you find the bone. We need to be better teachers in those habits and techniques. It's just something really important that I think that we just don't educate and don't hold accountability for, and the hospital does not hold accountability for. And every fluoro machine has how much time you use. The radiologist should be dictating it in their notes when they're reading our fluoro. The total fluoro time was 56 seconds. That's bad. The total fluoro time should be 10 seconds or under for that nail.
Right. It's amazing. Let's switch gears a little bit to back to burnout, and I want to talk about the concept of devaluation of the orthopedic surgeon. You know, in the sense of whether they're getting burnt out because they're doing revision hip and getting $900 from it from the insurance company, or they're not able to use the implant they want, or they don't get all the equipment, or you can't find a fluorotech. Again, that's the opposite side. You may need one, but you can't. You know, the loss of power, the loss of autonomy that I think Antonia talked about. Jeff, do you want to talk about that first?
Sure. I mean, I think you nailed another key way to describe burnout. And I think that's another great way to assess burnout. If someone feels devalued, they're much higher risk of burning out. When they feel valued, very unlikely to burn out. So I think if you probably clumped all the little mini topics and put them in the category of whether they demonstrate value to the person or individual or surgeon, or whether they devalue them, I think you would find that a very high percentage of these things are related to being valued. But it's amazing how many things, and you gave the example, there are many factors that make us feel valued. Sometimes it's monetary, sometimes it's, how you're being compensated compared to others. So, that is some ways a assessment of fairness. Certainly the whole system, when it regulates what we can, charge and get paid for surgery, that is a thing that's probably contributed to the overall theme nowadays versus way in the past. That when you consider how much education, how much time and effort that goes into doing those in a way that looks so easy, but isn't actually that, there's only a subset of people that have learned that skill to do those things. So I think that's a huge factor. But I would just add that you could probably take that with every one of the things that's a driver and recognize how the surgeon's perceiving it. And if they feel that they're not valued, then that's a driver.
Yeah, Antonia, some ideas on this?
So the hard part about valuation is perceived valuation versus true valuation, for example, right? So I think more and more facilities I'm going to use the total joints as an example, is saying, look, we want you to cut down the number of prostheses that you use because it's too cost prohibitive for the system if we allow to use every single system at 100% list cost. Well, if you restrict the number of or the type of implants I use, I'm going to see and feel like, well, I'm devalued because that's not an implant I like to use, or that's not something I want to use, or things like that. I think messaging is an important thing, right? And I think the other thing with valuation is having a seat at the table. A lot of times, a lot of decisions are made by hospital administrators, and they tell you, and they don't have a decision making. We talk about shared decision making with our patients, but we don't get shared decision making with our administrators, right? So we can implement that in a way so that we feel like we have a seat at the table. And as long as I know why, I feel better about understanding things. Someone's saying, look, we're going to say you can only use these 3 implants, but we're going to save $10 million in the system. And then I say to you, well, okay, we'll play ball, but we want a portion of that. And whether it goes in my pocket, whether it goes to research, whether it goes to education and the academic setting, it's going to be a little bit different. It's not going to go to the actual surgeon themselves. Then that makes me feel good. I'm happy to do so as long as it's not an inferior product, it's good for our patients, et cetera. As long as I understand the why and I'm part of the process, I think that makes you feel valued as an individual. The ones that are difficult are when you're saying, like, you need to do this pre-authorization and you ask why to the government and they say there's no response, right? Those are the ones that are much, much harder to feel valued in, because now you just feel like a cog in the wheel and you feel like you spend most of your day either on phone calls for pre-authorization, doing paperwork for it, or doing all these my chart messages or patient messages. So you feel like a hamster in a wheel where you don't have control over your time. So being able to hear from administrators that, hey, look, we hear you. So for example, there was an initiative where we try to reduce the number of my chart messages or patient gateway, whatever you want to call it. And that was something good because I think a lot of providers had complained about it for a long time and someone actually did something about that. So you're making sure we have that table and that voice is super helpful, I think.
Lisa?
Well, there's so many different ways in terms of feeling value that matter. So what I was going to say is I think everyone needs to realize that you don't have to have a title to make someone feel valued. And many people seek their value from leadership, and then decisions are driven by leadership without realizing that the lowest person on the totem pole is just as valuable. And we need to make sure that they feel that and that anyone in the team can help them. So that's why I want to stress that it's not just the leaders that are doing this as department chair or practice leaders, but everyone can make someone feel valuable. And also being cognizant of being inclusive also makes one feel valuable. And some people are going to have the efficiency model. Some people are going to have the practicality, and some people are better at the education, or some people, we have to look at what everyone can contribute. There's many different types of contributors to the team. There's worker bees that will just really keep on, no matter what time of the day or night, they're going to do these cases for you. But they don't like doing research. But guess what? They're a valuable member of the team. They each have something to contribute. So I think it's to realize the different gifts that everyone has, and realizing that this is a whole team effort. It's not just leadership. It's not just someone with a title to make someone feel valued.
There was a very interesting article in New York paper. I don't usually like to say New York Times, but I will say New York Times. And it was a whole article on young surgeons want work-life balance. The older surgeons say that's not the job. I think that's the title of the article. Now, I also have a slide that I show residents and say, sorry, fellows, we have fellows only. You cannot have work-life balance if you don't have work. Otherwise, you just have life-life balance, which is probably okay. But, is it a generational thing? Like even the awareness of radiation and the fact that, Antonia, you switched to no fluoro. Are there still, you know, dyed in the wool? I'm using fluoro. I've been doing it. I'm 62. And, is it how much is a generational thing? Antonia, why don't you start with that?
It's hard to change, honestly. I changed because of a health scare. I had a health problem and I said, you know what? I'm done with fluoro. It's out. I don't want any more of that. And you need an impetus to change. So there is a generational or exposure difference, I would say, right? To switch from fluoro to fluoro-free, that takes some trust either in yourself or another system. Now, I will say the surgeon that I trained with, who I did direct anterior with, did fluoro-free total hips. So I had training in that area, which is really nice. If you don't have that training, it's hard to move from what you're used to. I think what happens is the message now is don't take fluoro, as Lisa said, don't do it for 56 seconds, do it for 10 seconds. And if you know that and have a metric for limiting the amount you do, it is easier to change. It's some people will say, well, it's a crutch. It can be a crutch. So use other methods to do so. It's hard to change, I will say. So just reducing the amount will be exponentially helpful in that way.
All right. Jeff, the generational difference.
Yeah, I actually started writing a response to that one article just because I think it's very interesting. There's certainly generational components, but I think I think that's kind of describing extremes. that, that's the job. I think the older generation has to recognize that's not the job that anyone else is going to do anymore, because the job potentially was a job of full-on sacrifice, and they're not really getting the love of that sacrifice. So I think the younger generation says, one, they don't want to do that, and two, they want to have other aspects of their life that are as highly valued as their job. But I think the answer is it's not quite in the middle. The answer is a little bit different for everyone. And I think that's what's really key is, and Lisa kind of alluded to this, if you look at people as all being a valuable asset to this orthopedic world, then they all have a contribution, and you should leverage that contribution, and then that person is fulfilled. If they want to do it part-time, if they want to do it full-time, I know that the data shows that the volume of work is not a direct corollary to burnout. So some people are worried that if it's too much call, if it's too much work, that those people burn out. The reality is that if it's at the load that you want, then you're less likely to burn out. Now, that may need to shift with time. You may need to be taught these lessons that, hey, if you just work a lot and you're all for your RVUs, eventually that might not be satisfying and gratifying. So listen to the warnings of people ahead of you. But I think it's important that that dialogue is happening so that we understand, hey, the old school has a hard time changing and giving up. Younger folks may have a different perspective, but that isn't universal. I coach surgeons in the younger generations that are, almost quote old school, and I work with a lot of surgeons that are in mid to late career that are trying to navigate much more successful combinations of their life. So again, I think it's across the board.
We have two questions from the audience. Is Tiana Clemens. Tiana, if you want to show us your video, or you don't have to, and make your comment, and let's see what the faculty thinks about it. Unmute yourself, Tiana.
Go. Thank you, Dr. Kirschenbaum. I was just thinking of a phrase that I heard in the business realm, that when it comes to work-life balance, to think of it more as integration. And it was something that really stuck with me, because when I think of balance, I almost think of like the scales of justice, and how the different aspects of your life can be almost in opposition to each other. You have to give of something to give to the other. And so when I think of the word integration, I think more of those dynamics coming together in a way that will work for me. So I can tell you, while it might not be encouraged to ask me as a student, are you planning on having a family? Are you planning to get pregnant? Like, I am scared of those questions when it comes to like a residency application, but I also feel like I shouldn't be. I feel like I want to be able to share that. I want to be in a residency program where that is supported, not only for me, but for my fellow residents. So if we stop trying to think of the different aspects of our lives as these silos and individual pillars, and we integrate them, we'll be better able to not only support ourselves in what we do, but we'll be better able to support our peers, better able to support our patients. And this would lead to really a more holistic approach to care that I think needs to include the provider. So that's kind of what I was thinking.
Where are you a medical student?
I'm at Quinnipiac University in
Great.
Connecticut.
And when are you going to go into orthopedics? Just kidding. Just kidding.
Oh, I love it. Yes, thank you. I am an NM3, so my time is coming. You will see me on the other side eventually.
All right. Antonia, some comments on.
Can I respond to that just
Yeah,
real
please.
quick?
Jeff, whatever.
So Tiana, it's a great observation. And I think the terminology can be adjusted to each of us. Integration, work-life flow, work-life rhythm. I like the rhythm concept, but it takes a little bit of effort to kind of explain what I mean by that. But those are probably more helpful in our career than work-life balance. So that's a great observation. Just notice that some people do like the integration sometimes for some people makes them feel like they have to be doing a little bit of life at work and work in their life. And some people do like to separate that. Whereas the rhythm concept is just kind of noticing like when you're going through residency, that may be a very intense time for study and a couple other things, and you may have to give up a few things to get to a point in your career. Hopefully you don't have to give up much, and hopefully you carve out space for these other things that are very important. But then should be a point in the rhythm of your life or the rhythm of your day or your week that has this flow that helps you just enjoy it all.
Yep. So we have another comment from Zane Washington.
And might I just say, as a
Oh, yeah.
dancer, I love to accept the word rhythm. That is a part of my life. So I love that proposal.
Awesome. Is Zane Washington available? You have a comment?
Hi, yes, it's Janae. I know it doesn't look like
Sorry, Janae.
all right. My question was more so related to just factors now that are, I guess, more prevalent for younger students and surgeons to be that maybe weren't as prominent for like the older generation. For example, I believe Instagram came out when I was a sophomore in college. And it is still such a deep part of my life now. I feel like I can't wake up without scrolling online. And that makes it much, much more difficult for me to just kind of escape the realities of all of the things that I don't have as much time for as compared to my peers. And I think that that's just going to get worse. Like I have nieces and nephews who quite literally grow up on the internet, and it feels like they're missing milestones off of their life because they're always just online comparing themselves. And so it's just kind of those things, those features now that are much stronger that perhaps weren't before, and just how that maybe changes the way that people view sacrifice in terms of career. So I just wanted to know, like, I guess what have y'all personally pondered or thought about in regards to that? I'm sorry if it was a confusing question.
Oh, it's spot on. Who wants to take that? Lisa?
Social media is something that can be your friend or foe. And just like any habit that you have, whether it's a good habit or a bad habit, you have to temper it with reality. And if it is affecting your confidence level and you are constantly feeling like you aren't adequate, then you need to find a different way to support yourself so that you aren't reliant on social media. So that's one of the things you can't. 2 days ago or yesterday, I guess, no, it's Wednesday now. 48 hours ago was interview offer day, universal offer day for orthopedic residents. And people getting on social media and trying to see which programs came out with offers, or if someone heard from that, that's enough to drive someone crazy. So in those instances, I encourage you to stay away as a medical student. Do not use it as a measure of your self-worth. Surround yourself with people that build up your self-worth and do activities that build up your self-worth. Watch a video that will help you in your surgical technique instead of doing social media. Find a mentor that will build you up. So that's my message to medical students and to anybody about social media. Because there's a great diagram out there. It shows an apple on one side, like you're looking in the mirror, and on the back side of it, it's all rotten.
Wow. So I have a question to Antonia. We're going to switch gears a tiny bit. These are great answers. How important is it for you, or to you think to your colleagues, as a surgeon, to partner with a company that has solutions you need to eliminate stress? because we haven't brought in the big players in the room, the device companies, the pharmas. They have solutions. How important it is to partner with a company. I don't mean partner as necessarily as a consultant, but partner.
Um, Absolutely. It's one of those things where we want to reduce stress, right? In any way, shape, or form, right? Whether it be avoiding social media, and I am a social media person. I do like social media. I do note, this is a tangent. This is kind of a response to what Lisa just said, is that there's always the reality versus truth, right? The video portion is not always the truth of what you see. But from a stress perspective, I think there's multiple different ways that we can label stress, right? So, for example, I use an AI dictation system during clinic that has truly alleviated some stress of mine. And partnering with companies that do that is phenomenal. So that's the clinic setting instead of having a scribe, which is an expensive endeavor, but a wonderful thing to have. I've been able to use this AI dictation so that my notes are mostly finished. So I'm not finishing clinic at 5 or 5:30 and then staying till 7:30, 9 o'clock at night, finishing notes. That's one area. And the OR is the other area I would say is we want to reduce our stress. So one thing, yes, we talked about the stress of potentially getting cancer, but forget that. How about physical stress? After I finish a total hip replacement with fluoro on, I'm tired and I'm sweaty. So that's just a bad combination on multiple different levels. So if I can have less stress, that's helpful. Something that I have incorporated in my practice is robotics. And the reason I like robotics is because it reduces my stress level. I can do predictable procedures with technology, and that's super helpful as well. So and then in the post-operative care, right? What do I care about from a stress perspective? I want a patient to do well. So I've used a remote monitoring app, and that remote monitoring app allows me to see how a patient is doing with regards to range of motion, doing their physical therapy, doing their exercises. So whatever I can incorporate ways to stress less, there'll be a cost to it. But I think that at the end of the day, being able to do that from a surgical perspective is super helpful.
It's great. And as you talked about in the beginning, Antonio, when we talked about the idea of burnout and we have an hour, we probably need 55 hours. But we're nearing toward it as all these topic sessions happen, we get to the end so much faster than we want and with so many questions that we have. But I'm so glad we have brought this topic into right out here. This will be posted on LinkedIn, Spotify, and Apple Podcasts. It won't be posted on Instagram. Sorry about that, Shane. But it's okay. I'd like all the panelists to just give us a 2 to 3 minute sort of leaving message. We'll start with Jeff, then go to Lisa, then go to Antonia. How's that? Just randomly, I'm just going that way. Just a couple of minutes to sum up and where do we go from here?
Well, my biggest theme is if you want to experience wellness, you need to practice wellness. And so any one of these ideas that helps you be safer, have a longer, healthier, sustainable career, I suggest that you start working on it and practicing those habits. I think any one of these things, Antonia pointed out, is change management. And so some of it is change management for ourselves to notice where we don't like the exposure or what we're experiencing and how we can limit that exposure and improve our health and wellness in our career. I also just, I don't want to be labeled as the personal resilience guy. I want to be an advocate for organizational change and want us to change the culture that we're working in. And I think this is a great start to continue that. But there are baby steps along the way, but we need to support individuals that are doing the right thing.
All right, Lisa, some take-home messages.
Actually, I was going to let Antonio go first because I know she has something.
Oh, Antonia, go ahead, please.
I think the take-home message is do it the way that makes sense to you. I think the interesting thing about family planning, lifestyle, all sorts of things like that. What I always say is that there's an orthopedic surgeon who does it the way that you want to do it. I did my career a certain way, and Lisa did a different. Everyone on this call has done their career in different ways, and it's all worked out. So you don't have to be, I don't know, doing 10,000 cases a year. You don't have to, write 3,000 papers a year, unless you want to. And if you want to, you can find someone who's done that. So find someone, find a model, find a mentor, and then emulate that in the lifestyle you want to be. If you want to have kids during residency, have kids during residency. If you don't want to have kids, don't have kids. If you want to do anything like that, you will find someone in orthopedics who's done it. And that's the best part about it, is that you are not alone. And there are multiple different ways to find your integration in life.
Awesome. Lisa, you want to bring us home?
Yes, to bring us home, I just want to say we have people that are attendings in several years in practice. We have medical students on this call, and in order to help sum it up for everybody, the one thing I want to say is always keep an open mind to education, an open mind to changing your ways that you might have learned. If you're a millennial, open and keep an open mind to change the way to learn something different. And the old adage that you can't teach an old dog new tricks is wrong. We all can learn, and learning continues from the beginning to the end. And we all can contribute and help each other, and always, and please don't judge others, just bring someone up, turn around and bring someone up.
It's great. So I would like to say it's 8:01. I don't want to keep anyone from anything they need to do for their work-life balance, or their work-work balance. So I would say, first of all, a huge thanks to Antonia, Lisa, and Jeff, and all the people who spoke up, and the messages. And I want to say thank you, everyone, for a great session. We'll continue this. If you have articles or editorials you want to bring to JOEI, we will publish them after we read them and peer review them, of course. But except for that, we're okay. And I just want to say thank you to everybody, and this was a great session. Good night.